Dr. Patrick Green. Already getting claps. Dr. Green is an assistant professor in the Department of Internal Medicine section on gastroenterology and the associate program director for the Gastroenterology Fellowship Program here at Wake Forest. He obtained his Bachelor's of Science from Florida State University and then his medical degree from the University of North Carolina, Chapel Hill. He completed his residency and chief residency at the University of Miami in internal medicine and completed his fellowship in gastroenterology at the University of Miami as well. His major area of focus in both practice and research is inflammatory bowel disease, and he wanted me to add that he is the proud owner of the best beard in this hospital and possibly in the entire state of North Carolina. So, on behalf of the Department of Internal Medicine, please join me in welcoming Dr. Green.
Thank you. I had tried to convince him to use the term devilishly handsome too, but he didn't work that in. So I think everybody knows the way to sign in for attendance by now. So I'm going to be talking on diet and its role in gastrointestinal disease. So first things first, I want to let you guys know why I chose this topic. And actually, it had to do with some feedback that I got from one of the residents about a year ago. Under my suggestions for improvement, they felt that I talk a lot about poop and really didn't have any other suggestions to improve upon. So that one was a little bit odd to me, but when I got thinking about it, you know, in maybe a gross oversimplification of the GI tract, it really has two jobs. So number one, you're going to take in food and assimilate nutrients. And number two, you're going to get rid of what you didn't need in that. So I do spend an awful lot of time focusing on the second portion of that, but I guess that's one of the hazards of being an IBD doctor, so I think about that all the time. Now, the other thing that this talk is going to allow me to do is kind of address some of the really common questions that I get in clinic. So I can start off by saying, number one, yes, I do tie my own bow ties. Number two, no, this beard is not hot in the summertime. But number three, doctor, what do I eat? I get that all the time, and I'm sure you guys get it in your practice too. Everybody wants to know what they're eating and how it affects their illnesses, okay? So the other thing that I've been focusing on here a lot lately has been medical education. In fact, I'm currently working on a master's in medical education right now. And so part of my focus has been trying to integrate new technologies and trying to find ways to liven up my lectures. So we're going to try a technology that the residents are very familiar with. They use all the time, but we wanted to experiment using it for grand rounds today. So we're going to do some live polling things and some questions. So this is going to be one of the few times you're going to hear somebody say, you absolutely have my permission to take out your cell phones in the middle of my lecture and be looking down at it. So you'll just go to pollev.com and then Patrick Green 003 and be able to answer the questions. Now, I will remind all of you that some of these are live answers. What you text in is going to show up on the screen, so be polite. I don't have any financial disclosures. So as far as objectives for this talk, so overall, I'm going to sort of cover several of the major different diets and illnesses that we deal with. So I want you guys to be able to explain the difference between celiac disease and gluten intolerance. I want you to be able to list the different components of the 6-food elimination diet that we use for eosinophilic esophagitis. I want you to be able to explain the dietary modifications that we recommend for GERD in our patients, be able to explain the proper use of the low FODMAP diet, and also to be able to explain the role of diet in inflammatory bowel disease, because that's my passion. So we're going to start off with this. Now, we are having some technology issues, so I'm going to have you guys ignore this little security update thing in the corner. But go ahead, take out your phones, and tell me, what did you eat for breakfast this morning? See if it's working. Yeah. All right. I will also let you know that this is going to be a judgment-free zone. So Velveeta, I'm going to still pretend that's actual food. All right. So we can see there's a whole bunch of different things that people choose to eat, okay? Now, some of them are very good choices. Some of them maybe not so good. I will tell you, I'm not seeing my individual choice up there, so I had Pop-Tarts for breakfast this morning. Now, don't judge. They were the organic ones from Trader Joe's, okay? All right. So, Adam, how do we switch back here? Okay. All right. All right, so basically the things I want to cover in this talk. So I'm not going to be talking about diets that we use for weight loss, okay? That could be a whole topic all in and of itself. I'm not going to give you guys a comprehensive review on all the diets out there. I'm not going to extol the virtues of the South Beach diet versus the, low-carb diet versus the Paleo diet. I'm just going to talk about some of the ones that we recommend to our patients or discuss with them quite often. I'm not going to explore diet in all the conditions. Even if I just looked at all of the GI conditions that we treat, I wouldn't have enough time to talk about it. So I'm also going to avoid the topic of disordered eating for today. So now you're probably wondering, well, what is this talk going to be if I'm telling you all the things it's not? It's going to be an awful lot of hand-waving, okay? Diet talks are notoriously difficult to give because there's not really great data. The main problems you have with trying to collect data in diet studies are, number one, you get people like me enrolled in your diet studies. I last on a diet for about 3 days, and then I start cheating. So then your data is just completely thrown off. Number two, diet studies are notoriously hard to do, okay? They are very expensive. If you really want to do it in the best scientific way possible, to minimize the amount of cheating you get on the diet, you need to provide the foods for them, and that helps maximize compliance. That is very costly. The other thing is diet studies are notoriously short-term studies. So we'll look at putting somebody on a diet for a month and see how it does. But the question is, what do these diets do if you use them permanently? And that's probably the more important question to ask, but extremely difficult to answer. All right, so let's see if I can master this. All right. All right, so go ahead and tell me, what are the diets that you know of that you're interested in hearing about? What are the things that your patients are asking you about? Yeah, so we're already starting to hit on some of the very popular ones. So the Paleo Diet, the ketogenic diet, leaky gut, gluten-free diet. Intermittent fasting has been one of the really popular ones. I think about half of our fellows currently are doing intermittent fasting. So, all right, so I'm going to start off with one of the simplest ones, the BRAT Diet. Okay, I think we've all probably heard about this diet, probably from our mothers, okay? So it stands for bananas, rice, apples, tea, and toast, okay? It's used for acute diarrheal illnesses. Interestingly, it's not unique to our culture. It's something that's seen across cultures. So my wife is actually from Vietnam, and they have a version of this that they give to people when they're having a diarrheal illness. Their type of banana is slightly different. They tend to use the green bananas and some other things, but theoretically it's about the same. So what this diet is supposed to do is help reduce your stool volume, shorten the duration of the diarrhea, replace volume that you've lost, replace lost electrolytes, and possibly it might promote mucosal healing through the production of short-chain fatty acids. So what's our evidence? Okay, in adults, my grandmothers, all right? This has been something that's been passed on from generation to generation. So my grandmothers told my dad and my mom that's what they had to eat when they had an acute gastroenteritis. Therefore, my parents made me eat that when I was a kid. and therefore I'm likely to tell my kids, well, just have some toast, some bananas. It'll help soothe your stomach, okay? Unfortunately, that's about the level of evidence that we have for adults. So where the evidence does come in is from pediatric literature. So they've looked at studies in a lot of the developing world. So this one was a small study of a few hundred boys aged 5 to 12 months in Bangladesh. I think many of us are aware of the recent paper that came out about the use of parachutes that was meant to highlight the fact that you have to be very careful about how you apply studies to your patient population. And you really have to look and say, well, is the group that I'm looking at really reflected in the study that I've used as my data? So I'll give you, in adult literature, comparing it to a child, a boy aged 5 to 12 months is not quite the same, but it should be good enough. So what they did was they randomized to a rice-only diet, which was basically the standard diet that they used, versus rice plus cooked green banana or rice plus pectin. Okay, so what the bananas and the pectin are doing is they're supplying extra fiber. Okay, what they did see was that there was a reduction in the stool weight. All right, so you can see this here is your line with the pectin and then also the banana. And we saw a significant reduction. We also saw a significant reduction in the duration of diarrhea. So the advantage of the BRAT diet. So it does seem to reduce stool weight. I think a lot of the residents that have heard my talk that I give each month to the ones on the ward service about diarrheal illnesses would know that stool weight is actually one of the better measures of diarrhea. However, it's probably the least practical. I think the nurses would kill you if you tried to write, please weigh patients' stools daily to see how their diarrhea is doing. It does reduce the diarrhea duration. It's been shown to reduce the need for IVs and also oral rehydration. And that's largely what they use in places like Bangladesh where they don't have easy access to IVs. They'll give oral rehydration salts. And again, theoretically, it promotes healing through short-chain fatty acid production. So the disadvantages. People don't eat as much. If you're only eating rice, toast, and bananas, that's not going to provide the same caloric intake that you would on a normal diet. There's also reduced macro and micronutrients, and they've actually had case reports of kwashiorkor as a result of even short-term use of the BRAT diet. All right. All right. So, next question. Avoidance of which of the following foods is recommended to treat GERD by reducing transient lower esophageal relaxations? So it sounds like we have two favorites here. By and large, most people are saying caffeine and chocolate. We have a few more seconds here for responses. Going once, going twice. Sold. All right, the correct answer is chocolate. All right. So, there is no actual GERD diet. I'm just going to label it as the GERD diet. These are the recommendations that we give to our patients. So theoretically, there are foods that lower the lower esophageal sphincter pressure. Of course, with lower pressure, that means the pressure from the stomach can overcome that lower esophageal sphincter and have reflux of acid up into the esophagus. So things that reportedly do it: peppermint, chocolate, caffeine, and alcohol. So all the fun things in life. There are certain foods that also irritate the esophagus. Now, these aren't ones that are actually going to cause damage, but if you already have mucosal damage from acid reflux, then these might further irritate that already annoyed mucosa. So those are things that are acidic in nature: citrus, tomatoes, spicy foods, okay? Some foods actually increase GERD symptoms by slowing down gastric emptying. So we know that fatty foods do take longer to empty out of the stomach. So as they're sitting in the stomach, that means there's more pressure inside the stomach, and as it's churning away, more of the contents are going to reflux into the esophagus. We recommend that our patients eat smaller, more frequent meals, so that reduces the intragastric pressure. And then we also ask them to stay upright for at least 2 to 3 hours after they eat a meal, because if you lay flat, gravity is now allowing that acid or contents that you've refluxed into your esophagus to just pool there and doesn't help pull it down. So what's the evidence behind this? So what I've done here is I've grayed out some of the factors that aren't really diet-related, like tobacco, obesity, recumbent position, those kind of things. So this was actually a systematic review of a handful of different studies that have been done in the area. And you can see our levels of evidence. So by and large, most of the studies have insufficient evidence or conflicting data. A lot of other ones are based on expert opinion. What we do see is out of the few, so chocolate is one of the ones that actually does have case-controlled studies that do show it lowers the lower esophageal pressure and it worsens pH, okay? Caffeine actually doesn't have good evidence behind it, so that's why I say chocolate is really our correct answer on that last question. And then there are other ones that show no effect in lowering the lower esophageal pressure, but then may actually cause a worsening pH or symptoms, okay? So for example, alcohol doesn't really lower the pressure, but yet it still does create more acid in the stomach with 24-hour pH monitoring, and patients report worsened GERD symptoms. So let's move on to a gluten-free diet. This is another very popular one. In fact, an awful lot of patients are on it, and they don't even entirely know why. I think a big part of it has been it's very popular in just popular media. It's now very widely available. You go to virtually any store, and they'll have an entire gluten-free section. So it's supposed to be used to treat celiac disease, which is a gluten exposure-induced enteropathy. Gluten is a protein component that's found in wheat, barley, and rye. The treatment of celiac disease is avoidance of gluten in the diet, and it's as simple as that. Unfortunately, we don't have any other real treatments for it. And untreated celiac disease does come with its set of risks, so there is an increased risk of intestinal lymphoma if we don't treat it. So, all right, so compliance with a gluten-free diet improves symptoms in approximately what percentage of patients with celiac disease? Now, I should specify here, when I say compliance, I mean real compliance with the diet. So by and large, I think most of you seem to agree, and you're actually correct. It's more than 80% of patients that are compliant with a gluten-free diet will have symptom improvement. So this has been looked at. They've seen that approximately 56% of patients will have complete resolution of symptoms, and an additional 26% will have at least partial improvement in their symptoms, with only 18% having residual symptoms when actually compliant with the diet. Also important is serologic improvement. We see the overwhelming majority, more than 2/3, will have improvement in their tissue transglutaminase and also their endomysial antibodies. Now, one of my patients recently did introduce me to a new term. I did not realize that gluten is not just a noun, it's actually a verb. And she was talking about being inadvertently glutened here recently. And so this is a very real problem for patients. Some people are very, very sensitive, and they actually can have minimal exposure, even just cross-contamination from going to a restaurant where they've cooked a gluten-containing dish in a pan, and then just give it a quick rinse, and then toss the next gluten-free dish in there. And yet that still can be enough to cause some issues. So we do see that there is mucosal healing. Now, what we look at here for a cryptovillus ratio, what we're looking for is a 1-to-3 ratio. So I've highlighted that with this little red arrow up here. So what you'll notice is that before diet, a lot of people are abnormal, and there is an improvement, but yet it doesn't necessarily get back to normal. So yeah, we're making some headway, but there is not complete normalization. This is after 4 years of being compliant on a diet, okay? Now, There are some differences that are seen very quickly. So there's pretty rapid improvement, but it just reaches a certain point and doesn't continue to get better. We also do see a decreased number of intraepithelial lymphocytes on biopsies after compliance with the diet, but again, it's a trend towards improvement, but it does not go back to completely normal. We're not entirely sure the implications of not having complete normalization of your biopsies. All right, so we're going to get a little personal here. How much fiber do you eat in a day? All right, so in knowing your audience, for the most part, I don't really need to extol the virtues of fiber to you guys. Most of you know that fiber has a lot of good health benefits, and so as a group, healthcare providers are probably going to be better about taking in fiber in their diet. Most of you are saying you're into this 10 to 20 gram range, which is actually probably a very truthful estimate. Those of you that are saying you're above 50, I don't know if I entirely believe you. All right, so how does the general population do with fiber? Okay, I think I should, before I do that, we'll talk a little bit about the difference between gluten intolerance and celiac disease. So a lot of patients will come to clinic and they say, well, I have celiac disease because I quit eating gluten and I feel better. I have less abdominal bloating, I was having loose stools before and that got better. That does not necessarily mean they have celiac disease. Celiac disease still remains a rare disease in the population. They'll have similar symptoms, but what they won't have is serologic marker positivity. They won't have changes in their histology, so you're not going to see the increased intraepithelial lymphocytes. You won't see villus blunting, things like that. And the other good news is gluten intolerance does not increase the risk of lymphoma. So, basically what's happening here is this is a simple food intolerance. Much like you can be intolerant to lactose, you can also be intolerant to a lot of other things, including gluten. Okay, that's the main difference. So we oftentimes look at a low FODMAP diet. Okay, so that's one of the popular ones that I use for my patients that have symptoms that come with celiac disease, like abdominal bloating. Okay, so FODMAPs are fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Now you see why we go ahead and abbreviate it as a FODMAP. Those include fructose. This is not to say these are unhealthy foods. These can be very healthy foods, but they're just foods that you may not tolerate. Lactose, fructans, galactans, so beans, lentils, soybeans, those are all very healthy things to eat. Polyols, a lot of times, are artificial sweeteners, okay, and we all know those are ones that are notorious for causing symptoms like diarrhea and bloating. You ask anybody that you've given lactulose to, and they'll tell you it's sickeningly sweet and it makes you feel miserable. So the low FODMAP diet is really to help somebody identify what their particular trigger foods are, and we all have different trigger foods. You'll have things that you tolerate much better than I do. You have a different microbiome than I have, and that's probably what plays a role in this. Okay? Now, the low FODMAP diet is not intended to be a permanent diet, and this is the biggest mistake that I find people try with it, is they go on this diet and then they just stay on it. And there are entire books and low FODMAP cookbooks. And yet it's really hard to stay compliant because of how restrictive this diet is. So the way we should be using it is we should use it for a short term. They go on the restrictive diet for about a week or two. If they feel better, then that suggests something they were eating really was triggering their symptoms. And then we have to start identifying what those things are. So what we do is we start adding foods back one at a time. They give it a couple of days after they've added that food group back, and they see how they feel. If their symptoms return, that food is one of their triggers. If the symptoms don't return, that's a safe food for them. Now, the dirty little secret about the diet is that a lot of times the patient is going to find that it's some of their favorite foods. They eat those things all the time, therefore they get symptoms all the time. Now, what I do tell patients, the reassuring part in all of this is these types of symptoms don't really cause anything bad. It doesn't increase your risk of cancer. It doesn't increase your risk of dying. It just means you're going to feel a little bit uncomfortable. So if you know that dairy is one of your trigger foods and you love ice cream, you're an adult, you can decide how much you're willing to take the hit for your bowl of ice cream and see how you feel the next day. All right? So there are a ton of foods on the low FODMAP diet. So if you look at the column to the far left, these are the foods that we recommend patients limit. And I don't want you to read through the entire list or anything, but it's just to give you a sense of how many things we're talking about eliminating. And there's some pretty major food groups in there. So the low FODMAP diet most often is used for the treatment of irritable bowel syndrome. What they've looked at is a study with 82 consecutive patients with irritable bowel syndrome were either given standard diet advice or a low FODMAP diet advice. Now, this is not a randomized study. Simply what they had was they had a nutritionist that got hired, and so before the nutritionist was hired, they just assumed everybody had standard advice, and then after the nutritionist came into their clinic, they started teaching people the low FODMAP diet. What they did show was that there was a reduction in symptoms. 82% of patients on the low FODMAP diet did report that their bloating improved. 85% reported that their abdominal pain got better. Diarrhea was the only one that had a trend towards significance but did not quite reach statistical significance. And then other symptoms like flatulence, nausea, and fatigue all improved. There is some effect on the microbiome. So what we do see is that there's a reduction in bifidobacteria by going on to a low FODMAP diet. Whether or not this is sustained is not really known. This is people that have been on the diet for a very short term, for about 4 weeks, and then they went through and did some stool cultures. So now let's move on to the fiber, okay? So high fiber diet, that's something we have all heard about the benefits of. Fiber is a plant-based carbohydrate, it's non-digestible. It's been shown to have beneficial treatment for diabetes, heart disease, obesity. Of course, I'm a GI doctor, so I'm going to focus on the other stuff here, the hemorrhoids, constipation, and diverticular disease. Okay? So we already know, everybody said they eat kind of that 10 to 20 gram fiber per day. The US RDA for fiber is actually 25 grams per day. And in general, in the US, we fall well short. In the NHANES study, people were hitting about an average of 18 grams per day in males, 15 grams per day in females. So it's maybe one of those few things that men are doing a little bit healthier than women. So the standard American diet, or SAD diet, is actually very low in fiber. Okay? Studies, as we said, generally consider adding 20 to 40 grams to what the patient is already eating to be in a high fiber group. It depends on which study you look at as to whether they go up to 20 to 40. So what that gives us is a range of about 30 to 60 grams of fiber per day. So we all know an apple a day keeps the doctor away. Okay? An apple has about 5.5 grams of fiber. So an apple a day is not going to keep this doctor away. Okay? So in order to reach the amount of fiber you would need to get to that magic 30 to 60 degree number, you need to eat 10 apples per day, okay? How many of you out there eat 10 apples in a day? Okay, now, you can substitute any other fruit group or vegetable serving as an apple. There are very few people that are going to do it. I think I know at least one in the audience. My wife does an amazing job of how much fruits and vegetables she eats. I decided that I needed to try to help improve the amount of fiber I was taking in my diet. So I started cheating. So one apple is about equivalent to 1 spoonful of some of these powdered fiber supplements like Benefiber. Okay? So I know you all think that I'm just up here drinking my coffee. This actually is my fiber in here. So I wanted to point out I'm not just talking about this, I'm practicing what I preach. Okay? Now, you have to have several tablespoons of fiber. So you read on the bottle, and it'll tell you, you take 2 teaspoons of fiber a day. That's just 5 grams, okay? So realistically, you need to have more than that. So I take 2 tablespoons of fiber a day, all right? So let's look at some of the data here. So fiber actually does show some benefit for both bleeding and pain at defecation in patients with hemorrhoids. So they randomized 52 patients to receive 20 grams of psyllium fiber daily. And at the end of 6 weeks, they took a look at their symptoms. Now, bleeding and defecation, you can see there was a statistically significant improvement. Okay? There was not for pruritus or for rectal prolapse. At the end of 3 months, it does look like this was sustained, so bleeding and pain on defecation were improved. Now, how about for constipation? So they looked at 20 grams of fiber as a supplement to the patient's diet. And what they looked at, so there these two different graphs here. So the delayed rectal transit is reflective of people with pelvic dyssynergia. Okay, so they're ones that already have a neuromuscular disorder and are unlikely to respond to things like fiber. Okay, the delayed colon transit are the patients that have constipation for other reasons. So they're the ones that were really the main focus of the study. So what we do see is that adding 20 grams of fiber does increase does speed up the colon transit time. Now, you do notice there that there is a pretty significant drop, not quite statistically significant, but just on placebo alone. So when it comes to our guts are notoriously sensitive things. They're very responsive to our emotional states. They're very responsive to the power of suggestion. So just placebo alone is enough for people to feel like, okay, I'm doing something to help my bowels move better. Seems to help them move a little bit better. Now, it also does help decrease the stool frequency and also the stool volume, the stool weight, in patients significantly that have the delayed colon transit, so slow transit constipation, as compared to pelvic outlet constipation. So diverticulosis is another one of those big topics. A while back, there were some studies that were just sort of observations where they looked at patients from sub-Saharan Africa, and they saw that they had a very low rate of diverticulosis. They compared that to European men that had a very high rate of diverticulosis, and the only thing they really felt was significant was the amount of fiber they took in. Okay, so for a long time we just said, well, yeah, you should give people fiber, and that'll help prevent diverticula from forming. Now, there's data from the diet and health studies that actually suggest the opposite. So two important things about this little chart at the bottom. So number one, they broke their patients down into quartiles. So the lowest quartile took between 1 and 15 grams of fiber. That's a pretty big range. In fact, those of you that were saying you were into that 10 to 20 gram range, I would hazard a guess that many of you are actually going to fall into that lowest quartile. The second quartile, between 8 and 20 grams. The third quartile, 12 and 26. And the fourth quartile, some people taking up to about 84 grams of fiber in a day. I can't imagine that, all right? Now, what we do see is that the adjusted hazard ratio does show perhaps an increased risk for diverticulosis in the patients that are on the highest fiber content diets, not so much with the ones that are in the middle quartiles. I deal with this question probably once or twice a week. I scope somebody, I find diverticula, they say, oh, that means I have to avoid eating seeds and nuts and popcorn, doesn't it? Okay? This is something that we have taught patients for years and years. Okay? What we do know is, number one, diverticulitis is rare. So diverticulosis is common. Diverticulosis occurs in half to 3/4 of our patients by the time they're 70 years old. Okay? But only 10% of those patients will have an episode of diverticulitis during their lifetime. Of course, if you're thinking about it, 10% of 3/4 of the population is a large number of people, so you're all going to know people that have had diverticulitis. So the data shows us something different than what we traditionally teach people, though. When you look at the adjusted hazard ratios for popcorn and nut consumption more than 2 times per week, we actually see a decreased risk for episodes of diverticulitis. So that's the exact opposite of what we've been teaching people for years. And we see no difference with corn and some other things people didn't really look at. Now, that being said, I still have patients swear to me, every time I eat strawberries or every time I eat popcorn, I've had an episode of diverticulitis, and I tell them, fair enough, you don't need those things to live. If you really feel that you have to avoid those to keep from getting diverticulitis, by all means. But usually it's just bad luck. All right, so let's move on to the gastroparesis diet. So I don't know how many of you know about our section of gastroenterology and how it's sort of a national center for gastroparesis. The evidence for the gastroparesis diet largely comes from Ken Cook. All right. In fact, when we first join the faculty here, we get a little bracelet that says WWKKD for those times when you have that chronic nausea patient get admitted. What would Ken Cook do? So what Ken Cook would do is the Gastroparesis Diet. Now, a lot of this has been based on expert opinion and clinical guidelines, okay, with one little piece of data that's actually evidence-based. Using a small particle diet, okay, so what they said with this was these are foods that are mashable, okay, so they said, for example, you can take peas and you can mash them up, okay, so these are kind of softer foods. They break down into smaller particles very easily. They took 56 patients and they randomized them to receive a small particle diet versus placebo for 20 weeks. And what we saw was a significant improvement in nausea and vomiting, fullness, abdominal bloating, lower abdominal pain, and heartburn symptoms. Okay, so that small particle diet does seem to have an effect. Interestingly, that's not a part of the diet that we recommend to our patients. Okay, what we tell them is a low-fat diet. I've already mentioned to you that fat does slow down gastric emptying. Okay, a low-fiber diet. So fiber also slows down gastric emptying. So we want their stomachs to empty rapidly. Eating smaller volume meals. Obviously, if you eat a whole bunch, that's going to take a long amount of time to get through. But if you eat a smaller amount, even though it's going to take a while, they're not going to have as many symptoms. And then we tell them liquids probably empty faster than solids. Now, we don't actually go so far as to say small particle size, but that's kind of what the liquid part of things is getting at. So Ken's gastroparesis diet is actually a 3-stage diet. Stage 1 is essentially nothing but clear liquids and a few saltine crackers in a day. It's just meant to prevent dehydration as a bridge till they can go on to the Step 2 diet, and the Step 2 diet is meant to get them until they go to their permanent Stage 3 diet. Okay? All right, so we're going to try another question here. All right, so what is the most common food allergy seen in eosinophilic esophagitis? All right, so it sounds like most people kind of feel peanuts and tree nuts and dairy. All right, those of you that guessed dairy were correct. All right, so dairy is by far the most common. Wheat is also very common. Seafood and eggs are fairly uncommon. All right, so what we often use for patients with eosinophilic esophagitis is the 6-food elimination diet. We eliminate a lot of those common ones, so dairy, soy, wheat, eggs, peanuts, and seafood. What had been done before that, largely in pediatric patients, was an elemental diet. The big problem with an elemental diet is it tastes horrible. So compliance with it is extremely difficult. Usually you have to have the patient being tube-fed because they're not going to swallow an elemental formula just by how bad it tastes. So in pediatric patients, that oftentimes was a fairly easy thing to do. You had kids that were failing to gain weight because of the severity of their eosinophilic esophagitis, so they had a feeding tube that was placed for that. And so we could use that, and we would see improvement in their symptoms. So in adults, the 6-food elimination diet actually seems to have some benefits to the same level of the elimination, or the elemental diet rather. So by and large, it's about as effective as far as improving symptoms, but it's much, much more tolerable. Okay. There's also several different ways that that we try to implement this now. You can try, eliminating the most common things. So a lot of times we put people on a dairy-free diet, and we see how they do. If we were to do this, by the books, the correct way to do it is we put people on a 6-food elimination diet. We biopsy their esophagus to see if they've improved. If they haven't improved, then we have to explore other options. If they have had improvement in their histology, then we start adding foods back. And you have to add foods back one at a time, wait a little while, and rebiopsy. So by the end of it, they've had 8 different endoscopies with biopsies just to prove which foods are really the ones that are triggering their eosinophilic esophagitis. And sometimes you get to the end of it and you find out it's actually all of them. So in adults, we have seen that a 6-food elimination diet can statistically significantly improve symptoms. It also does improve histology. So after being on the 6-food elimination diet, we do see a significant reduction in their eosinophil count in the esophagus. And then when they go back on a regular diet, we see those eosinophils come back. Okay, so these are meant to be permanent diets. So in these last few minutes that I have here, let's go on to my one true love here, the role of diet in inflammatory bowel disease. There are a ton of diets out there for inflammatory bowel disease, and every patient wants to know what is the right diet. There's some compelling data, actually, that what we are eating is playing a huge role in inflammatory bowel disease. Some of my colleagues in Miami did a very interesting study. They looked at patients from the U.S., where we have a very high rate of inflammatory bowel disease, compared them to patients that were from developing countries with a very low rate of inflammatory bowel disease. What they did was they looked at these patients when they immigrated to the U.S., and they looked at their children born in the U.S. So children of immigrants born in the U.S. have the exact same rate of inflammatory bowel disease as children that have been here for generations. Okay, so their genes have not changed in one generation. It's something in the environment. Okay, the other follow-up study to that was they looked at those actual immigrants, and after 8 to 10 years of living in the U.S., their rates catch up. Okay, so we know that there's something we're doing here. We just don't know what it is. A lot of things have been proposed. Could it be some chemicals in the water? We do treat our water very differently than a lot of places. Maybe that's it. Maybe it's our diet. Maybe it's actually food preservatives or emulsifiers or other things that we're putting into our processed foods. We don't know what it is, but patients want to know, and they want to know how they avoid those things and get themselves feeling better. So one of the first things they looked at was a vegetarian diet for inflammatory bowel disease. So in theory, it works much like a high-fiber diet. Fiber, as we've mentioned already, increases short-chain fatty acid production, so your bacteria ferment that fiber and release short-chain fatty acids, which are anti-inflammatory. So what we should do is we should look for an increase in omega-3 fatty acids compared to omega-6 fatty acids. In the U.S., we eat a diet that's very high in omega-6 fatty acids, and those are pro-inflammatory. Omega-3s are anti-inflammatory. Now, the practice of a vegetarian diet, we have very, very few studies. There's been one small study in Japan, and it was a semi-vegetarian diet, meaning that the people just had to say, I'm a vegetarian, but I still eat meat. And that was enough for them to be considered in the vegetarian group. So that, to me, isn't real data. So we're not even going to show those studies. Oftentimes, you'll see our patients, especially in the hospital, get put on a low-residue diet. Now, a lot of us think that that's a low-fiber diet, but it's really not the same. So, yes, fiber is a residue. It's a difficult-to-digest food, but there are other things. For example, dairy is actually very difficult to digest, and so that should be on the low-residue diet as well. So some patients have gone on this as a permanent thing. What I use it for is actually in my patients that have symptomatic strictures from Crohn's disease, and that seems to be the best use for it. So as you can imagine, if you eat something with a lot of fiber, raw vegetables, the peels of fruits, things like that, and you have a tight stricture, those might obstruct that stricture and create some symptoms. So that's why I avoid those in those patients. But other than that, I don't use it for my patients just to help with inflammation or other symptoms like diarrhea. It's really only for that symptomatic stricture patient, and there's really no studies to support that. Now, the Paleo Diet. This is a very popular diet in gyms. People that are trying to bulk up, get some muscle. The idea behind it is you return to the diet of our hunter-gatherer ancestors. Okay, so that means meat from game, fruits and nuts. Okay, you should avoid refined sugars, processed grains, dairy products, because those were not a part of our diet, thousands of years ago. The theory behind it is modern diseases, heart disease, diabetes, other things, are probably a result of poor genetic adaptation. We just have not had enough generations to really adapt to our rapidly changing diet since the Industrial Revolution, when we really took on large-scale farming. So this also has not been studied in inflammatory bowel disease, despite the fact that a lot of patients go on it, and a lot of patients say they feel much better while on it. Now, this is one of the diets I'm still not sure how I feel about this one. The specific carbohydrate diet was actually designed by Sidney Haas in the 1920s, but it became very popular after a book by Elaine Gottschall in the mid-1990s. So the story behind this is she had a daughter at the age of 4 diagnosed with ulcerative colitis, and for 4 years had hospitalizations for flares and was on steroids and all kinds of different attempts at medications. Nothing got her better until she met Dr. Haas, and he talked about this diet. She put her daughter on this diet, and she went into complete remission. She kept her daughter on the diet for a year. She did well throughout that entire year. She took her daughter off the diet, and years later remained in remission. That is the power of this diet, which sounds fishy, right? So, that's why I'm not so sure about it. Now, the theory is you should only take in simple monosaccharides, glucose, fructose, and galactose, because they don't really require digestion. You just absorb them primarily. So bacterial fermentation of poorly digested carbohydrates results in byproducts that cause inflammation. But yet, bacterial inflammation from some things can actually release anti-inflammatory short-chain fatty acids. So what you're trying to do is give those bacteria the right things to ferment to reduce inflammation. So there have not really been controlled studies that have shown it, but uncontrolled studies suggest improvement in symptoms, lab scores like CRP and SED rate, and some of the endoscopic scores, although that data is we'll say squirrely at best. Now, I actually, I'm involved with the study here at Wake Forest called the DINE CD study, where we're looking at our Crohn's disease patients, and we're randomizing them to receive a specific carbohydrate diet versus a Mediterranean-style diet. They go on the diet for 6 weeks, and we see if they have symptom improvement. The advantage to the study that we're doing is that we do provide them all the foods. Of course, all the other dietary study limitations exist. So it's short-term at 6 weeks. And I'm sure even at that, people are going to cheat on the diet even though they get all of their foods and snacks provided for them for 6 weeks. Okay, but data is pending on it. All right, the anti-inflammatory diet, or IBD-AID diet, is very, very similar to the specific carbohydrate diet. So you modify some of these carbohydrates. You try to restore intestinal flora by taking prebiotics and probiotics. You decrease saturated fats, so those are the ones that are high in omega-6 fatty acids, and you increase omega-3 fatty acids, so it has some components to the Mediterranean-style diet. You try to identify their food triggers and replace missing nutrients, and then you modify food textures. So there's one randomized study that was unblinded, 40 patients. The interesting part about this is they took 40 patients, and only 11 patients actually did the diet. So of those 40, a quarter were able to be studied. What they said was 100% of those 11 patients saw improvement in their symptoms based on the Harvey-Bradshaw Index. So that's a symptom scale we use for IBD. And 100% were able to downscale their medication regimen, but they don't define what that means. So does that mean they went from taking 40 milligrams of prednisone down to 38 milligrams, or does that mean they were able to stop biologics and come off of all medications? We just don't know, okay? And the other limitation was that study was only a 4-week study, okay? So in general, I tell my patients, high fiber, high omega-3 fatty acid, low omega-6 fatty acid. You can consider fish oil supplements, consider a Mediterranean-style diet, avoid sugar foods, and turmeric may have some anti-inflammatory properties. So the ultimate question always comes down to, okay, so you've told me all this stuff, so what can I eat? Okay? So in general, I tell my patients, fresh foods are probably better than processed foods. High fiber is probably better than low fiber. High omega-3 fatty acids is probably better than omega-6 fatty acids. So those types of diets are things we find in Mediterranean diets, a lot of Asian diets, African diets, many parts of Central and South America. We just don't see it here in the U.S., okay? So not the standard American diet. That's horrible for you, okay? So you should be eating things like this, all right? And I will tell you, these two dishes, the top one in the green bowl was my dinner last night that my wife cooked. So that's pho. So it's a Vietnamese chicken noodle soup, essentially. And then homemade ramen that she made here recently as well. Other things that are on the Mediterranean-style diet, so lean meats like chicken and fish, lots of fresh fruits and vegetables. Not this stuff, okay? So this is what we tend to eat in the U.S., all right? So perhaps you should think about eating here, okay, this seems a little sketchy, right? This is actually my wife's aunt's house. This is her kitchen. This is the house that my wife spent many of her summers in central Vietnam, in rural central Vietnam. And I had a wonderful Christmas dinner there 2 years ago that she prepared in this kitchen. Now, if you think about it, she got her chicken from right there, okay? She got her vegetables from the garden that's right at the side of the yard. So everything was homegrown. There was not a single processed thing. And growing up and eating those types of foods is probably a lot better for you than the kind of foods that I ate when I was a kid. So those are the kinds of places you should be avoiding. All right? All right. Well, thank you very much. I'd be willing to answer any questions.
Any questions?
One of the world authorities on celiac disease is Peter Green. Is he your daddy?
No. Yeah, Hugh?
What are some resources that you like to provide to patients, maybe not necessarily IBD patients, but I have a lot of normal healthy patients asking for dietary advice? What are some places to point to?
Yeah, that's a big challenge because the internet, as you are well aware, is filled with misinformation. There's not a whole lot. I tend to steer people just to our own patient handouts that we have, especially the ones that are in Epic. I've looked through those in general. Those are pretty good. You know, when it comes to IBD patients, the Crohn's and Colitis Foundation really has a wide variety of resources. And actually, you could look on their website. They have stuff on some of the diets, like a Mediterranean diet and high fiber and those kind of things. So that's another good source as well.
So,
Dr. Thomas?
one of the things that a lot of our patients are asking about is we're in lung disease and we give a lot of antibiotics and everybody's getting diarrhea with their antibiotics. They ask about probiotics. You know, I don't have a specific answer. I usually encourage people to, you know, eat some yogurt and there's bazillions of supplements out there. Do you have any advice for how to respond to the probiotic question?
Yeah, so we get this in a lot of different areas too. And so what I tell people is, okay, in general, probiotics are not harmful. They may or may not be helpful. There are, you know, thousands of species of bacteria that belong in our guts. Of them, we can grow out a few dozen of them, which means those are the ones that we can turn into pills and market. So statistically speaking, there's a low likelihood we're going to stumble upon the right ones that you need because of the antibiotic you've been on recently. That being said, there's very little harm to them. So I tell people you can try them out. If you feel better on them, wonderful. We've just happened upon the right ones. If you don't feel better on them, the way they can hurt you, I suppose, is in the wallet. Okay, they're expensive. So if you try it and you don't get better, don't keep taking it. Maybe try a different one. The ones I recommend most commonly are VSL number 3, and that's just a holdover because that's really the only probiotic that has been shown in a randomized trial to have any benefit at all. And that actually is in my my IBD patients, my ulcerative colitis patients that have had a total proctocolectomy with an ileopouch anal anastomosis, so J-pouch. High dose VSL number 3 can actually prevent proctitis or pouchitis. Beyond that, nothing. So VSL number 3, Align, Culturelle, those are kind of very easy ones to get and reasonably affordable. If they want to go to the ones that they have to put in the refrigerator, okay. Those are much more expensive, and I don't know that they're going to have any other benefit other than those. So.
All right, if there's no additional questions for Dr. Green, I'd like to thank everybody for coming out. Don't forget to fill out your evaluation forms, please.